afternoon. We're delighted to see all of you up here in Kirksville. It's snowing. It has been snowing all morning. It was about 3 or 4 inches of snow when I came in, and at the rate things are going, it may be 5 or 6 when I leave here in a minute. At any rate, we're glad to have you all here, and we're delighted to have Dr. Ben Schrandt, who will be doing a presentation on anesthesia. So I'm going to turn it over to Dr. Schrandt, and you guys be nice.
All right, thank you, Janet. And for those of you out in the nether regions of Missouri, I'm Ben Schrandt. I'm one of the anesthesiologists here at Northeast Regional in Kirksville, Missouri. And to those medical students, I may have lectured to you in the past when you were here in Kirksville during the pharmacology course. And today, we're going to talk about local anesthetic drugs, some of the things, how they work, why they work, what are some of the problems when we're using local anesthetic drugs. Some of this we've talked about, and one of the interesting things about this talk is, as some of you are unfortunately about to find out, I'm a former chemistry major, and so we're actually going to be talking some hardcore organic chemistry today, which is a lot of fun. So, surprise, here comes the chemistry questions. And so let's start with, this was probably put up when you were a sophomore, day 1, organic chemistry. We have to go all the way back 6 or 8 or 10 years ago, and we need to actually talk about some functional groups when it comes to chemistry. And so I can hear from people in Kirksville or St. Joe or Cape who can name the functional group up here on the top. I guess it's the top left of the screen. That's an amine. Okay, we've heard from Kirksville, so somebody else who's online, what's the one on the top right? It wasn't that long ago. Okay, anybody? That's an amide or amide, however you want to talk about it. What about the one on the bottom? That is an ester indeed. Way to go. And so we're going to talk about the differences between some of these drugs and what all of this chemistry means here in the next few minutes. And we'll also be probably referring back to this slide. So when we talk about local anesthetics and you open any chapter in a textbook, you usually see, there's 2 categories and there's a table. And the point is that all local anesthetics fall into one of 2 categories, whether they're an ester or whether they're an amide, and we'll talk about that in a little bit. But one of the things that all of these molecules have in common is that they all have an amine group, a basic amine group, and what that is telling us is that all local anesthetics are bases. And the point is that this amine can accept a proton. When we talk about what is a base molecule is a proton acceptor versus what is an acid?
Donor.
A donator, exactly. A proton donor versus a proton acceptor. The other thing that we have to talk about, it's imperative to talk about when we talk about local anesthetics and differentiating one from another and when we should use one versus the other, is a pKa value, which we have to, again, go way back to chemistry. So what is a pKa value? Every molecule has a pKa value. Whether it's a protein, whether it's a local anesthetic, what is a pKa value?
It's the ratio of charged to uncharged plus pH.
Almost.
It's a pH in which you have an equal amount of charged and uncharged.
Yes, a pKa value is basically if you set the molecule at a given pH, if you set the molecule in a pH at its given pKa value, half of the molecules will be protonated and half of them will be unprotonated. And so we have to think about more biochemistry. We have to think about cell walls and what makes up a cell wall. And of course, what makes up a cell wall is a phospholipid bilayer. And if we are to charge a molecule, we probably all remember that if you charge a molecule, in this case if we protonate that amine group on the local anesthetic molecule, it is not going to want to go across the phospholipid bilayer at all. And so we can harness a little bit of the chemistry by kicking the local anesthetic molecule more towards the unprotonated state. We'll talk about that more in a little bit. Now, so if we have all these molecules, these local anesthetics, and we've injected them around a neuron, and we come to some sort of equilibrium between, we have some protonated molecules of lidocaine and we have some unprotonated molecules of lidocaine. As I mentioned earlier, only the non-protonated, the uncharged form, can actually make it into the neuron. This is a little bit of a problem because it's the charged form that actually does the work inside the neuron. It's the charged form that actually blocks the sodium channels and stops potentiation of the action potential. And so once the molecules diffuse into the neuron, they actually establish a new equilibrium, a new set point between protonated and unprotonated molecules, and this will happen because like everything in nature, it has to come to an equilibrium. So there will be at least some measure of protonated molecules in the neuron that are able to actually block the sodium channels. So more on the pKa value. As we said earlier, the pKa is the pH at which a given molecule will be half protonated, half non-protonated. In the case of local anesthetics, the pKa values range from 7.5 up to 9, and we all know that that is in the realm of the bases. So if we take a prototypical example like lidocaine that everybody is familiar with, everybody knows about it, the pKa value of lidocaine is 7.8. Now that the actual value, the pKa value, does not change. The pKa value for lidocaine at a given, temperature and pressure, what have you, never changes. What does change is that if we alter the pH that the lidocaine is swimming in, the number of molecules, the ratio of protonated to unprotonated forms of lidocaine will actually change. Well, in the case of a physiological pH, or what is typically physiological pH, 7.4, that is more acidic than lidocaine's pKa at 7.8. The point is, the environment is the pH of the environment is lower than the pKa of the molecule. So over half of the lidocaine will be charged. It'll be in the protonated form. That amine group will have picked up an extra hydrogen, and now it doesn't feel like going through the phospholipid bilayer and actually helping us. Obviously, lidocaine typically works. Now, you can run into major problems with this. Say if you're wanting to drain an abscess in the ER or something, it's red, it's hot, and it's angry, and most of us have probably seen this. These patients, you just can't get them numbed up, and that's very simply because the area that you're trying to numb up, the area that you're trying to localize, has a very low pH, and it's just protonating all of your lidocaine molecules as fast as you can put them in, and they're refusing to go into the neuron where they can actually do their work. So, as far as more differences between these molecules go, I talked a little bit already about amides and esters. And really the only difference between amides and esters has to do with their method of being metabolized, where they metabolize, how quickly they're metabolized. Esters follow a lot of the same, or at least in my head, kind of the same pattern that you saw back when you took organic chemistry. What happened in organic chemistry if you put an ester in a round bottom flask and put a Bunsen burner underneath it? What happened to the ester? Nobody knows? That's okay. it cleaves right here. You end up with a carboxylic acid and an aldehyde. The point is that's a very easy reaction to take place not only in lab but in your body as well. And in the case of esters, they have very short half-lives. They're metabolized by the plasma cholinesterase enzyme, along with some of the other anesthetic drugs that we use as well. In contrast, amides, they have very long half-lives. They hang around definitely a lot longer, and they're metabolized in the liver. Most of the local anesthetics that we use are definitely amides, partially because what's the point of injecting a local anesthetic if it's just going to be metabolized pretty quickly? One thing that is important to note is that when it comes to nerve blockade, not all neurons are equal. Okay, we learned about A fibers and A delta fibers, C fibers. They're not only do they carry different, not only have different roles physiologically in the body, but they also have a different propensity to be blocked. And one of the things that we watch for in the realm of anesthesia, especially when we're doing like a spinal on somebody, we're watching for a decrease in blood pressure, we're watching for that sympathectomy. Those are the easiest fibers for us to block. Fortunately, followed right on the heels is pain and temperature. Lastly, and it's less of a big deal, is basically motor function. There are some additives that we put in our local anesthetics on occasion. Epinephrine is kind of the classic. And it has a function of prolonging anesthesia because it causes some intense vasoconstriction. It also can give you some feedback alpha-2 activity if you happen to catch it at a synapse. The other advantage to using epinephrine is that you can actually use a higher dose. Everybody memorized for their step 1 boards the toxic dose of lidocaine with and without epinephrine. Well, that's why you get less systemic absorption when you actually use epinephrine. And depending on the scenario, you may be able to take advantage of the local vasoconstriction that you get if you need to sew up somebody's skin that's bleeding or whatever. In the case of anesthesiologists, when we go up to dose an epidural, we actually, our first dose that we always do is a mixture of 1.5% lidocaine, and it has some epinephrine added to it. And that's simply to help us detect an intravascular injection. And why? Why would we bother with the epinephrine? What would we be looking for? Heart rate, yeah, we can see some tachycardia from it. Anything else? No? Okay, we'll kind of get to that. We kind of talked about it. So a little bit more on the metabolism side of things. We talked about amides being metabolized in the liver. Some of the metabolates of certain local anesthetic, prilocaine and benzocaine, can cause methemoglobinemia. Other drugs can cause it as well. And so if I'm, I don't ask my patients if they're having methemoglobinemia, but what do I need to be watching for as a provider? Or if you inject somebody with, you doing an EGD on somebody, spray their throat with benzocaine, do the EGD, what are some things to be watching for after the procedure? What may raise the alarm to suggest methemoglobinemia? No? Glad we're talking about this. Let's see. So methemoglobinemia is simply, we know what hemoglobin is, okay? We have the heme component. It's, of course, held together by an iron atom. And what occurs in methemoglobinemia is that iron atom oxidizes to the 3+ state. And what occurs is a kind of a strange constellation of symptoms in these patients. These patients get cyanotic, and by cyanosis it means they appear blue, okay? They get hypoxic. If you were to draw some of their blood, say for a gas, because you're concerned about them, their blood looks kind of brown. And because of the way that the methemoglobin absorbs light with the pulse oximeters that we use, their pulse oximeter tends to read right around 85%. Anyway, that we already talked about. Okay, so when we talk about how a local anesthetic works and why it may or may not work, we've talked a little bit about the pKa already. We've talked about how the pH affects things, and we talked about lipid solubility. And lipid solubility, when you think about what the local anesthetic has to do, unfortunately, it actually works on the inside of the neuron. So it's to the advantage of you as the provider to use a local anesthetic that actually has some lipid solubility, because it actually has to be able to get through that phospholipid bilayer where it can get inside the neuron and actually do its work. Since these molecules bind to sodium channels, which are, of course, made up of protein, the duration of action of the drug is going to be determined largely by, what kind of affinity do these molecules have for the sodium channels that they're binding to. We've talked about some other things as well, like epinephrine. One thing that I think is really neat is that these drugs, they can bind to an intraneuronal sodium channel in any state, but strangely enough, they have greatest affinity for these channels that are in the open and in the inactivated state. And when you think about that, what that means, if I put an interscalene block in somebody, that block would technically actually set up fastest if I had them start using their arm a bunch of times, or if I started stimulating their skin below the place where I put the block, because that will make those channels fire faster and with a higher frequency. As far as the pH is concerned, most of you have probably also heard about actually alkalinizing the drug itself. And so we can take a bottle of lidocaine, a bottle of whatever local anesthetic of choice. We consult our little recipe book, and we can add some bicarbonate to the mix. That, of course, raises the pH of the ampule or whatever we're using, and that drives the equilibrium so that the local anesthetic molecules have they've been driven more towards the side of being non-protonated, and that can speed the onset time. They get driven in to the molecule simply by a concentration gradient. So let's talk about some of the signs of toxicity, of actual local anesthetic toxicity. We kind of touched on methemoglobinemia, which is interesting, but it's definitely something you would see less than some of these actual physiological side effects from local anesthetic overdose or intravascular injection. One thing that is very important, I think, for anybody to know if you're going to administer local anesthetics to people, is that the neurological system provides the very first sign of overdose. And I think this is very important for people who are using local anesthetics. If you're in your office, you're numbing something up, you're going to take off a toenail, whatever the case may be. Patients will complain of these things first. Hopefully not a seizure, okay, but they may say, my ears are ringing, I have a funny taste in my mouth, whatever the case may be. And that is a sign for you to stop, okay, because they're getting likely a really nice dose of local anesthetic intravascularly, or maybe they're just a lightweight. If you keep going, these patients will have a seizure. Now, fortunately, in the case of a local anesthetic-induced seizure, it's treated just the same as any seizure. I'm kind of tempering this with the fact that you should know that as an anesthesia provider, I frequently inject local anesthetic intravascularly, before almost every case, before I give somebody an induction dose of propofol. They get a little IV dose of lidocaine just ahead of the propofol for a few reasons. Number one, propofol kind of burns, and it can kind of help that unpleasant sensation. And there's some data out there talking about lidocaine gassed.
How much do you inject?
How much do I inject?
Before propofol, and how much?
I usually don't. I think when I look at like Hippocrates, it talks. I want to say it says like 1 per kilo. Personally, I usually, for a typical adult, I usually do anywhere from 40 to 60 milligrams. Some data has suggested decreased cerebral blood flow, helping to stop the rise in intracranial pressure with intubation, helping to diminish bronchospasm when the tube tickles the cords, whatever. It seems a little bit like a kind of a panacea. I'm not all that impressed with it, but it certainly doesn't hurt something. The point is, there are people who do complain of having a metallic taste in their mouth or having ring in the ears as we inject this. It's not all that common. As far as neurological side effects are concerned, different local anesthetics do have a greater propensity to cause these. Lidocaine and tetracaine being the most common. Not too many people use tetracaine, but there are probably a lot of providers in here who are very familiar with Bupivicaine. Other things that could occur is mainly for an anesthesia provider, if you're going to be putting in a spinal, cauda equina syndrome, which is basically direct toxicity to the nerve roots, which doesn't typically concern the primary care provider too much. We'll skip transient neurological symptoms. So, on to respiratory effects. Lidocaine, unfortunately, depresses the hypoxic respiratory drive. And it can cause apnea in that way by just depressing the hypoxic respiratory drive, if that is your patient's primary dysfunction. Or if you injected it in some manner that you've caused the patient to become apneic. In the case of an anesthesiologist, we could accidentally cause a phrenic nerve block. Actually, we do this pretty frequently. Every time we put an interscaling block in our patients, it's very common. Somebody will complain of shortness of breath after they have their shoulder surgery, and we get an X-ray, and the diaphragms are just unequal because we have a paralyzed diaphragm on one side. Other issues could include actual anesthesia of the brainstem, so lidocaine or other drugs actually acting on the brainstem if, say, the patient is having an ophthalmology case and needle got a little too deep. That's of course going to cause somebody to become apneic. And we have occasionally seen what's called total spinal anesthesia. This is most common if we're placing an epidural catheter. We dose that catheter with an epidural-sized dose of local anesthetic. Unfortunately, we weren't aware of it, but the catheter had migrated into the subdural space, and now we've given an epidural-sized dose of local anesthetic into the intrathecal space, and that can cause what's called a total spinal, and a lot of things that would go along with total spinal, which includes paralysis of a lot of things, and that's of course going to include the phrenic nuclei. I talked a little bit already about local anesthetics relaxing bronchial smooth muscle. That's one of the reasons that we do like to use it just before we put somebody to sleep. As far as the heart is concerned, all local anesthetics can depress myocardial automaticity, cause vasodilation, and that's simply because the heart moves its electronic impulses with sodium channels, just like the rest of the body does, and the lidocaine acts a little bit indiscriminately. Any you can see a constellation of symptoms, anything from bradycardia, hypotension, complete heart block, whatever that may be. One thing that's very important to note here is that if you're going to have a cardiovascular toxicity, some sort of arrhythmia, an arrest, whatever the case may be, it's important to know that cardiovascular toxicity will occur at higher doses than you'll see versus someone who says, well, my ears are ringing. And that's important, and that's because we get phone calls every so often, somebody who is doing an in-office procedure, numbing somebody up, and they tell us, well, their patient tasted metal, their patient had their ears ringing, do I need to worry about their heart, about throwing them into asystole? The simple answer is probably not, because if you were wise and you stopped, you have likely not given them a dose of local anesthetic that is going to be high enough to throw them into some sort of arrhythmias. Now that's not to say that local anesthetics and lidocaine don't have their place anymore. It's fallen a bit out of favor, but when I first learned ACLS, lidocaine was actually built into some of the ventricular arrhythmia algorithms.
Dr. Schrandt, is that true of all locals or just lidocaine that you're cardiovascular?
No, that would be true of that's a broad statement. It's true of all of them. I mean, now I can't stand here and say, well, it's 100%. But if your patient complained of ear ringing and you stopped,
I just didn't know if Bupivicaine was the same way where you expect to.
Speaking of, so over the past few years, intravascular bupivacaine injection has kind of, I guess, emerged as kind of the bad boy when it comes to local anesthetic toxicity and cardiovascular toxicity, and it can cause lots of problems in the realm of the heart. Low blood pressure, heart block, a lot of these things we've already talked about, arrhythmias. Different people are at different risk for these. People who are pregnant, people hypoxic, acidotic people, which we'll talk about in just a little bit. The interesting thing to note about bupivacaine is that when you have your bottle of bupivacaine, it is not a pure drug. Like a lot of the drugs we use, which some of you may or may not be aware of, it has isomers and enantiomers in it. And so that's one thing that is very important to know for in a couple slides from now. If you have a patient who's experienced cardiac arrest from an intravascular injection of bupivacaine, the resuscitation can be long and nasty because of bupivacaine having a lot of problems. And unfortunately, it's much more difficult in the patient who's hypoxic and who's having acidosis. Well, unfortunately, that's what happens when you go into asystole. So Ropivicaine has emerged, and Ropivicaine is one of those isomers that's found in the bottle with the bupivacaine, and some smart scientist at some smart drug company figured out how to isolate these two drugs and separate them one from the other. It has a lower lipid solubility, and it is far less likely to put the patient into some sort of arrhythmia. So here in Kirksville, we have switched, at least the anesthesia department, if we're doing a large dose of local anesthetic for an epidural, for a peripheral nerve block, we have switched almost completely to using Ropivicaine. Levobupivicaine is a sister molecule of Ropivicaine. We don't have it in the U.S. Ropivicaine has been shown to be slightly less potent than bupivacaine, which is, I guess, fortunate or unfortunate. But if you look on the back of our everyone gets the garbage journals, but we get those, and it's got the picture of the lady going through rehab for a knee therapy, and it says, well, Ropivicaine is less likely to cause motor blockade. So the good people at the Ropivicaine company have taken that lemon and turned it into lemonade. As far as actual resuscitation, from an intravascular bupivacaine injection and a cardiac arrest resulting from that injection. Unfortunately, there is no uniform protocol, and that's because these are so rare to actually have this happen. Like most problems, like most adverse events you experience in a hospital, your initial focus, if this happens to you, needs to be on your basic ABCs and your traditional ACLS. Actually, I guess it's changed from ABC to CAB. Anyway, I put this in quotes here because one of the articles I read said, epinephrine remains a first-line choice of medication. And we'll look at some studies in just a few slides to see what you think. The best way to deal with this is to not have to deal with that. And so that means if you're injecting local anesthetic, whether it's in the skin, whether it's in someone's back, whatever the case may be, you should of course aspirate first. Consider incremental injection. Inject a little bit, aspirate a little bit, inject a little bit more. Talk to your patient as you're doing this. Find out if they're having any signs and symptoms of an overdose. And of course, be vigilant for it, be watching for it. If this is something that concerns you, you should have the patient on a monitor, especially if you know you're going to be injecting around a large artery or a large vein. So, in one of these drugs versus the other, Bupivicaine versus Ropivicaine, and the literature tends to focus on these drugs a lot, and that's because they're more long-lasting than other local anesthetics. They're more long-lasting than lidocaine, and so it makes sense if you're going to poke a patient with a needle, why would you not want to use a longer-lasting local anesthetic versus something that's going to wear off sooner? Anyway, resuscitation after a bupivacaine toxicity versus ropivacaine is much more difficult. That's for a few reasons. Ropivicaine is faster cleared, and the sodium channel blockade reverses a lot faster. The bupivacaine just has a higher affinity for those drugs, so it can hang on to the sodium channels longer and cause you problems longer, cause that malignant arrhythmia longer. So kind of the way that has developed over the past few years when it comes to local anesthetic toxicity, they call it lipid rescue. This little protocol was discovered accidentally. There was some laboratory, they were looking at rats who were deficient in carnitine, and you may or may not remember, carnitine is one of these enzymes that's found in the membrane of the mitochondria, okay? And it's absolutely essential for metabolizing fats, okay? For breaking these things down and turning them into acetyl-CoA and making ATP from it. Anyway, somehow somebody was looking around one day and they found out that these carnitine deficient rats had sensitivity to these bupivacaine-induced arrhythmias. And since they were messing around with these lipid emulsions and seeing what was going on in their mitochondria, they kind of switched the focus. Well, they thought, well, we'll give them toxic doses of bupivacaine along with this lipid that we're studying in their mitochondria and see what happens. And they were much more resistant to having asystole. And they were giving absolutely mammoth doses to some of these animals, 10 milligrams per kilogram. You know, that's like, absolutely deadly. And they were able to resuscitate and keep some of these animals from dying after they were giving these. Obviously, this is not found in your ACLS book, so you shouldn't start throwing intralipid at somebody who comes in the ER for a cardiac arrest. Now, what is interesting is that this protocol has trickled into the operating room. We have emergency manuals right by anesthesia machines, and one of the chapters in there is lipid rescue and what to do in bupivacaine toxicity, and it talks about how to treat it using these methods. Fortunately, human case reports are very rare utilizing lipid rescue, for one, because it's relatively new, for two, because people are careful, and actual bupivacaine toxicity and asystole is very rare in itself. Some articles have recommended, instituting this after standard measures fail. You can see the dosing here, kind of the regimen. There are a few different regimens out there. I'll talk to you a little bit about where this one came from. But this seems to be the one that is mostly agreed upon. It's the one that is listed when you go to visit the American Society of Anesthesiologists website. This doesn't show up very well. That's just a bag of white stuff. That's intralipid. Some of you have probably seen it. Some of you have not. But intralipid is just simply a TPN mixture. Okay, it's something that you give to that you typically give to a patient who needs some TPN. They're not going to be able to eat for a while. It contains a lot of lipids, and it's white. It looks almost just like our propofol. Intralipid is what has emerged as the lipid treatment of choice in terms of a bupivacaine-induced cardiotoxicity. So there's a gentleman in Chicago, Dr. Weinberg. He's an anesthesiologist, and he has been leading the charge in terms of intralipid and lipid rescue and what to do about bupivacaine cardiotoxicity. And he did some. I wish these studies were larger. 15 rats. That's not very many rats. But the point is, he started giving really large doses to some of these critters. This particular study, and you can look it up. It's in my references. Metabolic and hemodynamic measures were significantly improved with lipid compared to epinephrine. And notice I wrote epinephrine in here. I'm just going to. Here's a previous slide. Epinephrine remains a first-line choice of medication. And so I bring that up because some of the research that's emerging is starting to cast doubt on that statement. Now, I want to be very careful here, and that's not to say that epinephrine is not a first-line choice in a typical patient with asystole or VFib or VTAC. I'm talking about this only in the realm of someone who is having asystole from an intravascular bupivicaine injection. Here's a couple of the graphs from the study that I just mentioned. They're kind of messy, but what we're seeing here is, of course, blood pressure on the y-axis versus time on the x-axis, and we can see at minute 1, we can see the rat or whatever animal in question tanking to no blood pressure because they've gone into asystole. And I guess if you look at the triangles, that's the epinephrine line, and we can see as a function of time, epinephrine definitely jumps out the gate first and makes everything look good. Some have postulated, well, that's from the vasoconstriction that you're seeing, whatever the case may be. But as you see, as time marches on, the square boxes, that's the lipid box, okay? And so where epinephrine slowly starts to trail off and do basically no better than saline, in this case after 10 minutes, intralipid definitely appears to be a bit superior. The same is true down on the bottom right here. That RPP, that stands for rate pressure product. It's just the blood pressure times the heart rate in the case of these animals. And again, you can see the lipid, the animals that receive the intralipid are performing far better from a hemodynamic standpoint relative to those who got epinephrine, which again appears to be almost just as efficacious as saline. Here's another author. He looked at lipid resuscitation again in rats with and without epinephrine. they actually made their control group as lipid, versus, typically we think of a control group as getting saline. They used, relatively low epinephrine doses, and by that I mean, as a function of weight-based dosing, lower than what like a human would get. And what they concluded was that epinephrine doses actually resulted in worse outcomes versus the lipid controls. I say caution again. If someone needs epinephrine at this juncture, it's probably still questionable if you should withhold epinephrine. Okay, this is not giving epinephrine to somebody who has indications for it is definitely not gospel yet. Okay. Here's a graph from that study, and again, we have that rate pressure product on top. And again, what you can see is that the lipid group performed very, very well. And the lipid group was matched only by the group of animals that received lipid and the lowest dose of epinephrine. The other animals that received higher doses of epinephrine actually performed far poorly. And one thing, if I read these studies, they talk about that acidosis could be a precipitating factor in causing that toxicity, and is the acidosis that could be being precipitated by epinephrine causing these animals to be unable to be resuscitated. There's actually lots of other articles out there about lipid rescue, and there's more and more emerging about using lipid rescue for molecules and other substances that are beyond bupivacaine and beyond local anesthetic toxicity. There's an amazing one. If you read it, it's almost too hard to believe, but they talk about a patient who coded twice, and 50 minutes after coding again, someone suggested using intralipid. They gave it and they got a pulse back in a minute. And in the case of this patient, she had overdosed on bupropion and lamotrigine. There are lots of other cases out there for other drugs as well. It's definitely a cool and emerging field if it's something that you want to look into. Are there any questions? Yes.
So maybe some more specifics on what would count. Like if you're in the office and you're doing, say, trigger point injections, and opted to use Bupivicaine because they're going to get, maybe 12 hours relief. So where would you, say we have a healthy 40-year-old, where would you start thinking a large dose would be? Say, and you're using, say, 0.25%. And say you have a 70-year-old with COPD, where would you think a large dose would be?
Well, in terms of what's a large dose versus small dose, really all you
intermuscularly
going AM.
Yeah.
So all you really have to do is go to your chart and you look up the max dose of bupivacaine, which is 3. Yeah. And then you just do the math. So in the case of bupivacaine, if you're using, you said 0.25%?
Yeah.
So if you have 0.25% bupivacaine, that bupivacaine is actually 2.5 milligrams per cc. And you would want to make sure that you don't exceed that dose. Talk to your patient as you're injecting them, especially if it's someone you're concerned with. In the case of an intercostal block, that warrants even a little bit more care. An intercostal block has been shown to have the fastest absorption of any peripheral block you do. It'll get sucked intravascularly the fastest, and don't exceed your toxic dose. And aspirate and talk with your patient as they're doing it, as you're injecting them.
Really, you're not going to see anything occur in terms of arrhythmias if you're under the 3 milligram per kilogram dose. You shouldn't.
You shouldn't. Now, if you inject a whole bunch intravascularly on accident, you might get a transient. Well, my ears are ringing, Dr. E. or I'm tasting something strange, whatever the case may be.
All bets are off if you actually go intravascular.
Yeah.
It's blood level.
You should be okay.
So if you go intravascular, there are reports of even very tiny doses causing a problem. But typically, the problem with this is there are cases of people that have had bupivicaine that it actually occurred 1 to 2 hours after the injection because of blood level. So you could do all your aspiration, blah, blah, blah. But the typical people in the office, it's more us or people that are doing large volumes. If you're just doing trigger points, unless you just really got right intravascular.
Well, there's sometimes where I'm doing some prolotherapy where probably, I guess, I'm probably still less than 25 cc's total.
A 0.25%.
Yeah.
So you're probably, I mean,
Yeah.
renal impairment, there are things that can affect this. But I would say if you use 25 cc's, you should probably watch that patient for a while. And it's a spectrum of, usually it starts with neurological, but bupivicaine lags heart. So of all of them, bupivicaine is the scariest.
Are the different anesthetics max doses, I assume? So if someone's already pretty much, you're giving them about as much lidocaine as they probably should get, it's not safe to use any of the others on top of that?
Yeah, you should quit.
Here's some Bupivicaine, like you're just done with locals.
Yeah, you should quit because you could potentially be saturating receptor. They're going to work on the same receptors like I talked about. So, yeah, you shouldn't switch guns. You should stop shooting. Other questions?
No, Ben, I was going to mention
Yes.
it wouldn't necessarily, if you're in your office, if you do a lot of in-office procedures that involve local anesthetics, it might be something to look into to consider, knowing where the closest interlipid is or keeping some interlipid on hand because there's always, the reality. Just to kind of throw that out there for those of you that do in-office procedures.
And quite
Sounds like
honestly,
it's going to happen 2 hours later. Though.
well, it can. I'm just saying you're not necessarily safe if, oh, I did the procedure, I aspirated, nothing happened, they're fine, 10 minutes later you let them leave. It's all about blood level. So if they have renal impairment and you use more than you thought, 2 hours later they can have a problem. Very rare. And it's usually for us that are using high volumes. And then we stick in a catheter and keep the drip going. So they never get a break. It's like you did a big bolus and then you just keep giving it to them. But to me at this point, if a patient started having neurological symptoms, I'm going to grab the interlipid. I'm not going to wait and say, okay, is there a PVC? You're just going to say, where's the interlipid?
Because, the interlipid itself may prevent them from furthering on, and it's not going to hurt a patient to get, basically some fat, might be fat.
It's only like 200 cc. The emulsion.
You mean total?
Yeah.
It just depends. Your bolus, you do a bolus or size.
Anything else? All right. Thanks for listening. Other sites in Missouri.